Module Overview. By the end of this module, you will be able to recognize non-standard cardiac arrest scenarios that require adapted CPR and BLS approaches, apply modifications for drowning, hypothermia, trauma, pregnancy, overdose, infectious diseases, and confined space rescues, maintain rescuer and patient safety in high-risk or challenging environments, integrate special considerations with existing protocols without compromising effectiveness, communicate critical information to EMS and advanced care providers in special situations. Section 1. Why special considerations matter. Standard CPR and BLS training often assumes the victim is an adult on a firm surface, the environment is safe, the rescuer has space to work. Reality check. Arrests occur in water, on boats, in moving vehicles, in snow, on construction sites, in dangerous neighborhoods, and in infectious environments. Victims can be infants, pregnant women, trauma patients, or people with underlying medical conditions. Rescuers may have to adapt immediately without delaying the start of care. Accreditation reference, AHA 2020, Guidelines and ILCOR consensus emphasize that flexibility in resuscitation is key to increasing survival rates in real-world scenarios. Section 2. Drowning victims. Mechanism. Oxygen deprivation due to submersion leads to hypoxic cardiac arrest. Key adjustments. Remove the victim from water quickly, but safely consider personal flotation devices and spinal precautions if diving injuries are suspected. Start rescue breathing immediately while still in shallow water or as soon as on firm ground. Provide 2 initial breaths before starting chest compressions. If alone, give about 2 minutes of CPR before leaving to activate EMS and retrieve an AED. Why rescue breaths first? In drowning, the primary problem is lack of oxygen, not heart rhythm disturbance. Ventilation reverses hypoxia. Diagram suggestion. Flowchart showing drowning CPR sequence. Case study. During a lifeguard shift, a 14-year-old boy was pulled from a pool, unresponsive and cyanotic. Immediate in-water rescue breaths restored spontaneous breathing before EMS arrival, demonstrating that rapid ventilation is life-saving in drowning cases. Section 3. Hypothermia. Mechanism. Cold temperatures slow metabolism, heart rate, and breathing victims may appear dead. Key adjustments. Handling gentle sudden movement may trigger ventricular fibrillation. Check pulse and breathing for up to 30 seconds. Continuing resuscitation longer than normal. Some hypothermic patients recover after prolonged arrest. Remove wet clothing, insulate the victim, avoid active limb rewarming to prevent afterdrop. Sudden core cooling from cold blood returning to heart. Accreditation note. ILCOR advises, no one is dead until warm and dead. Case study. A skier was buried in snow for 45 minutes with no detectable pulse. After 2 hours of CPR and gradual rewarming, spontaneous circulation returned, illustrating extended efforts in hypothermia can succeed. Section 4. Trauma-related arrest. Mechanism. Massive bleeding, airway compromise, or spinal injury. Key adjustments. Prioritize hemorrhage control. CPR without stopping. Major bleeding is ineffective. Use jaw thrust instead of head tilt chin lift if spinal injury is suspected. In multi-trauma victims, airway and bleeding take priority before compressions. Diagram suggestion. ABC sequence modification in trauma. Catastrophic bleeding arrow, airway arrow, breathing arrow circulation. Section 5. Pregnancy. Mechanism. Enlarged uterus compresses major veins and arteries, reducing blood return to the heart. Key adjustments. Perform standard CPR, but manually displace the uterus to the left during compressions. If advanced care is available and no ROSC within 4 minutes, initiate perimortem cesarean to improve survival chances of both mother and baby. Positioning. If possible, Tilt the mother 15 to 30 degrees to the left to relieve pressure. Case study. In a hospital setting, a pregnant woman at 32 weeks gestation was arrested during a seizure. Left uterine displacement combined with rapid advanced interventions resulted in both mother and baby surviving. Section 6. Drug overdose and poisoning. Mechanism. Respiratory arrest due to central nervous system depression, e.g. opioids, or cardiac toxicity from poisons. Key adjustments. Provide ventilation promptly. Oxygenation is the priority. If available, administer naloxone, opioid antidote, without delaying CPR. Avoid mouth-to-mouth if poisoning is suspected. Use barrier devices. Accreditation. Note: WHO and AHA both recommend integrating antidotes like naloxone with standard resuscitation when available. Section 7. Infectious disease outbreaks. Mechanism. Risk of disease transmission during rescue. Key adjustments. Use gloves, masks, and eye protection when possible. Consider hands-only CPR for lay rescuers when airborne infection risk is high. For healthcare providers, use HEPA filtered ventilation devices. Example: during COVID-19, the AHA recommended compression-only CPR for bystanders and minimizing aerosol-generating procedures without PPE. Section 8. Confined or moving environments. Examples: airplanes, elevators, small boats, trains. Key adjustments. Secure the environment. Stop the vehicle or move the victim to a stable surface if possible. If unable to move the victim, adjust kneeling compression angle for maximum depth. Use mechanical CPR devices if available. Section 9. Coordination with advanced care. Never stop CPR until the advanced care team takes over. Clear signs of life are present. The scene becomes unsafe. Communication tips. Relay what led to the arrest. Describe interventions already performed. Mention any special considerations, e.g., hypothermia, pregnancy, poisoning. Section 10. Summary. Special considerations require immediate recognition and adaptation. Following standard CPR without adjustments in unique situations may reduce survival chances. Accreditation guidelines demand that rescuers be flexible, informed, and prepared. Documentation and handover. Accurate and timely documentation is crucial. ROS key time, oxygen, ventilation, and perfusion data, interventions done post-resuscitation medications, and fluid administration, next of kin communication records. Transfer documentation if moved to ICU or another hospital learning outcomes for Module 8. By the end of this module, you will be able to define and describe all stages of post-resuscitation care. Prioritize interventions immediately following ROSC. Recognize the importance of targeted temperature management (TTM). Identify neurological signs and understand delayed prognosis evaluation. Address ethical, legal, and psychosocial issues in the PRC phase. Accreditation compliance. This module aligns with international CPR and critical care guidelines, American Heart Association, AHA, Post-Cardiac Arrest Care Standards, European Resuscitation Council, ERC, Post-ROSC, Care Recommendations, UK Resuscitation Council, RCUK, Hospital and Pre-Hospital Guidelines, World Health Organization, WHO, Critical Illness and ICU Protocols, ISO 21001:2018, Educational Organization Management, ISO 29993:2017. Quality of learning services outside formal education.